since all of you are here, I think we can start.
Yes.
Yes? Okay. Okay. So welcome everybody to this round table discussion about digitalization and what we can learn from the corona pandemic and about telemedicine in OECD countries. This is Forum for Health Policy. We are a non-profit think tank with the aim to boost innovation and development in healthcare and elderly care. And digitalization in healthcare is one of our main focus areas. And I'm very happy that we have these distinguished guests that participate in this roundtable discussion. Telemedicine is being used across OECD countries to deliver healthcare in a wide range of specialities and different settings. And I would also like to point out that a growing body of evidence suggests that care delivered via telemedicine can be both safe and effective. But we still see a very small fraction of telemedicine when you compare to, for example, the total cost for healthcare. So we will start with Tiago Oliveira Hashigushi from OECD. You have written a report bringing healthcare to the patient, and I'm very happy and proud that you are participating in this seminar. And you have promised to give us a short presentation to start off this round table discussion. So please, Tiago.
Thank you. Thank you very much for the invitation, first of all. It's a pleasure to address this meeting today. It's a shame we couldn't meet in the island in Sweden, but this is good as well. So even before the COVID-19 pandemic, interest in digital technologies like telemedicine was already growing. Patients were more and more interested in how digital technologies could meet their needs, and policymakers were increasingly exploring digital models of care to tackle challenges from aging to chronic multimorbidity to gaps in workforce supply and skills to growing health spending, a share of which is wasted or even harmful. With the pandemic, interest in telemedicine has skyrocketed, as we all know. We published earlier this year, in January, a report looking at how policymakers were responding to the growing demand for telemedicine, the impact that these services had on healthcare systems and patients, the barriers and enablers to wider use, and we provided tentative policy implications for countries seeking to maximize the benefits and limit the risks. While the project was published and the work was conducted before the pandemic, I will try to focus on how parts of the work relate to the pandemic. So, even before COVID-19, economies, governments, and societies were already going digital, and new models of care were becoming possible. And these models of care were showing that the costs of older models of care are far too obvious. Among the entire population, including the unemployed, an estimated 2.4 billion hours of time is spent and $52 billion in opportunity costs annually to seek care. In the United States, these are the numbers. Across 23 OECD countries, 11% reported unmet medical needs in 2015-16 due to barriers in access, and 65% barriers due to waiting times. Telemedicine, the use of ICTs to deliver clinical services at a distance, from remote patient monitoring to real-time or asynchronous consultations, has been touted as a way to break down these barriers. But telemedicine is more than a Skype call. While the majority of OECD countries allow at least some form of telemedicine, policies vary widely in terms of the types of telemedicine allowed, the funding and payment schemes used, requirements in terms of distance between participants, eligibility of health workers and patients to participate, patient consent, and finally integration with traditional face-to-face health services. Very generally, there are two ways in which national and regional governments can affect the provision of care by telemedicine. One is through legislation and regulation. The other one is through financing, by which I mean both infrastructure as well as provider payment and reimbursement, i.e. by limiting the out-of-pocket payments for patients. In federated countries like Spain, US, Australia, or countries that have splits like Sweden, for example, the way legislating and financing is split can lead to some issues and problems in incentives. Now, before the COVID-19 pandemic, use was relatively limited, but it was growing. It is important to understand that data on telemedicine is very patchy. We don't really have comparable data from OECD countries on the number of consultations provided or how much is spent. We don't have this data, and we certainly don't have time series for these data. What we do have is anecdotally some evidence that before the pandemic, we were seeing a steady increase in the number of providers and the number of patients using telemedicine and in the volume of services. Telemedicine, however, still represented a small fraction of all healthcare activity, both as a share of total volume and total spending. Since the pandemic, there's been a massive increase in the number of consultations provided and investments. In the US, for example, telemedicine funding has jumped 258% this year, reaching almost $1 billion in the first quarter of 2020. In France, we went from 40,000 consultations a year to 400,000 in just a few months. In Belgium, we've seen rapid movements in terms of legislation. Now, I will come to this a bit later and speak to what we can expect later on to happen. However, it is important to point out that for some patients, from seafarers on board ships to prisoners to people living in rural areas to indigenous people in rural communities, telemedicine is the only effective way to access certain types of healthcare. And we mustn't forget that for some people, this is the normal way of getting care. Now, while there are promising signs that telemedicine delivered through telemedicine can improve quality, efficiency, and equity, there is still uncertainty, and there is the potential for new inefficiencies and inequities. The majority of OECD countries has not evaluated their telemedicine programs or services. So there is really a lack of consistent, rigorous evaluations of these programs. This is not ideal. Healthcare delivered through telemedicine, however, if you look at the growing body of evidence, as you mentioned, does seem to have benefits. It can be delivered safely, and it can even be cost-effective. And it can do this across a number of conditions and specialties, which is quite positive. The potential benefits for certain territories are obvious. Through better access, timeliness, coordination, and continuity of care, telemedicine helps patients find the right care at the right time in the right place. By promoting knowledge sharing and continuous learning among healthcare workers and patients, preventing unnecessary and costly downstream services, reducing provider travel time, and allowing a higher volume of consultations, telemedicine services can increase efficiency and productivity and thus promote cost effectiveness. But it's not all positive. Telemedicine interventions can stimulate frivolous demand and promote cherry picking, wasting limited budgets on unnecessary medical care for the worried well, meaning the young and healthy patients. Unfortunately, the generalizability of evidence on cost effectiveness is hindered by poor reporting standards. Furthermore, economic evaluations tend to miss important cost savings outside the health system, such as reduction in travel time and reductions in pollutant emissions. Based on the feedback from country experts, most barriers to change are not technological. They are organizational and institutional. Most barriers stem from a policy environment that is not supportive of broader uptake. Financial hurdles include payment mechanisms that effectively disincentivize new models of digital care, a lack of clarity on medical liability and jurisdiction, insufficient interoperability and inadequate ICT infrastructure, a shortage of digital skills among health workers and inadequate training, and finally, privacy, data, and information security and governance. On the demand side, barriers include limited health literacy, and digital divides along demographic and socioeconomic factors that inhibit the effective use of telemedicine among those that are most likely to benefit from it. This, of course, risks amplifying existing inequalities. How has COVID changed this picture? First, I'd like to thank my colleagues at the OECD who have been week on week putting information on our database of health systems response. You have the link at the slide. I encourage you to go and have a look. What we've seen is really a very rapid response. And in some ways, this has been very interesting because it's shown that when there is no alternative and when there is political will, capital, and investment, things can happen very fast. Things that we were told for years that were very difficult and could not be done have happened in months and would take decades, have taken decades in some cases. What am I talking about? Expanded provider payments. So essentially paying for these services, providing reimbursement and payment for patients and for providers. If you don't pay for something, it's very unlikely that it will happen, or it might even introduce inequalities. There have also been the creation of new services and platforms. Some examples are quite clear and easy to understand why they're beneficial, like certificates for sick leave done electronically, electronic prescribing of medications, but also some interesting and at the moment extremely important services like end-of-life care done via telemedicine, or allowing patients in home care for the elderly to communicate with their loved ones at the moment when visits are curtailed. And there have also been new guidelines and regulations. This is essentially relaxing restrictions on the use of telemedicine. So in France and in the US, there were, before the pandemic, policies that so-called continuity of care policies. So in order to see a telemedicine specialist, you would have to have had a consultation face-to-face with that specialist. This has been relaxed in the US and France. It's no longer a requirement. In the US, there's a number of other regulations that have been relaxed. There have also been new legislation, which now allows the use of telemedicine to take place from the beginning. And finally, very high-level political encouragement. And this is an important part of digital transformation. You need high-level political encouragement, capital, leadership. And you've seen this, for example, very visible cases in the UK. Matt Hancock has been a very vocal supporter of digital transformation in health. And I'm not necessarily saying that's all positive, but it is an important step. What has happened to the growth in the use of telemedicine? This is one of the few sets of data that we have. It's from the US, from the Commonwealth Fund, and it shows the number of telemedicine visits growing quite substantially as a percentage of the visits before the pandemic. You do see that it reaches about 14% compared to the baseline, and then it starts to drop around April, around the time that some clinics and face-to-face services started to open up again. Now, we can go in the Q&A, we can go to the reasons behind this and what I think are the reasons behind this. I do think that it's important to remember, and this crisis will show that telemedicine is a solution for some problems, but it's not a replacement of face-to-face care. And it only takes, all of us on this call and watching can consider the healthcare that they have on a yearly basis, how much of it could actually be virtualized. Just think about that. And then you have an idea of what telemedicine could be helpful for. So how can countries promote appropriate use going forward? The good news is that there are many examples across the OECD of how to use telemedicine to improve quality, efficiency, and equity. They provide a blueprint for wider and appropriate use. Country experiences suggest that telemedicine services work when they are centered on the needs and preferences of patients and communities. So they are not solutions and searching for problems. They have to first start with a problem, and then you find a solution. And these are the ones that work best, we've seen. They have to benefit from a conducive policy environment that facilitates the emergence and spread of good telemedicine practices. I'll go into this in the next slide. And they have to be supported by a culture of continuous learning in which the evidence is both applied and developed as a natural outcome of the care process. So policymakers need to make use of telemedicine benefiting people, but also limiting the risks. They should ensure that telemedicine services provide benefits and clear benefits to patients. They are more likely to be adopted by physicians. They are more likely to be used by patients. But these are local solutions most of the time. So you need a policy environment that helps share the best practices across nations, within nations, but also cross-border. And finally, you have to accept that in that sharing and in that experimentation, there will be failure. But failure is not necessarily bad as long as you learn from it. This is essentially the essence of the learning healthcare systems approach. And this has benefits for telemedicine. In our perspective, it would help a lot, but it's a great approach for a digital transformation in general. So the priorities are really for government, focusing now on what policymakers can do. The priorities are really to help it happen, to let it happen by helping it happen. And also to resist the urge to make it happen, meaning to come from the top down and institute things. What we have seen is that is probably not going to work very well. And we have examples of that in the NHS, Connecting for Health, Connecting for IT, etc. So in the context of Sweden, for example, address geographical divides and digital divides is an important barrier, because we know from access to broadband that broadband access in rural households is far below access to broadband in urban households. These are structural barriers to the use of telemedicine, and of course, when we consider COVID, this is going to have an impact on use. The second priority is really to scale up sustained financing and payment. It's important to not only pay providers and patients, but also to invest in infrastructure to ensure that people have access to these technologies, not only in their houses potentially, but also in the clinics. And finally, and this is, I think, in the long run is going to be a very important one, is to promote clarity through guidelines and legislation. It is important to tackle medical liability, jurisdiction, certification, security, privacy. All these things are barriers to wider use. If I, as a physician, don't feel confident on the risks that I'm taking on by participating in a teleconsultation, I will be very, very careful. I will be very cautious and conservative. And so, in some ways, this will limit the growth of the technology and its potential. So going forward, especially in the context of cross-border provision, this is going to be an important one. So I hope I stuck to time. I thank you again for the opportunity to tell you a little bit of our work so far on this topic, but also we have other work on COVID-19, and I would and on the digital transformation. In fact, now I would encourage you to check this out on our website. Thank you.
Okay, thank you so much. I don't know how can you applaud on that? Would you like this? So thank you, Tiago. Very concise and interesting presentation from your side. And I will actually hurry on and then come back to you and see the comments from the rest of the team here. So Ulf Österstad, welcome. You are operation manager at Bra Liv, a primary care health center, and you're also saying that you're one of the first public finance digital units in the world. Yeah, that's great. You have read the report, and I've asked you to give some comments from your perspective and a national perspective. So please, Ulf.
Thank you. Delighted to be here. Thank you for the report. This is a pre-pandemic report, and it's not covering the growth boost. In Sweden, it's especially for the established actors or the actors that were under establishment. we must underline that the ones that hadn't started or wasn't going to start, they still hadn't had any of the boost in this. Another thing not covered in the report is the fact that telemedicine is a non-contagious way of doing things, and we had reports saying that the classical ways of examining the patients, like lung auscultations, there were coming in reports worldwide that wasn't giving the information needed to address COVID-19. So that is outside, but I think it's relevant. From a national perspective, I can note that Sweden did not participate in any of the interviews that were in the background material. So anyway, it also covers the fact that Sweden has a high penetration of internet mature population, and I think that's correct. And I don't think that even though some geographical aspects that not everyone has it, enough people has it to make an impact. So I don't think it's an obstacle in Sweden for having bigger penetration. The report states, and you made it very clear, that it's effective for the patient, and that is something that is ongoing discussion in Sweden. That the caregivers, they would like to have it effective for the caregivers. And this is not an entirely Swedish perspective. I have spoken to GPs on King's Fund, which you had taken one of the reports from, and they were exactly in the same place. They were saying exactly how can we save time for the caregivers. And I think that is an obstacle, and I think it's not only national, but in Sweden it is a big thing, and it's not so easy to make just that proven. So that's the case. You say that there are no specific legislation in Sweden and that all is covered within our system and the reimbursement system, and that is partly true. We have a Swedish loophole, so there actually is a way of getting money, and the political way here is that they have tightened the loophole bit by bit, not to make it all die away. But of course, in the long run, we must have a legislation for it. But that is, I think, covered by Göran Stiernstedt's report, and I don't think that's the big issue right now. It's mostly, the issue is that the caregivers who don't have telemedicine, they are worried about losing money. It's not about how they use the incentives to start using telemedicine. And if you look at the report, there's also one thing that is very interesting. Sweden is one of the countries where we have it established, but small. And it is because you only measure what is being done with telemedicine. If you instead would measure what is being done not with common visits, then there would be a completely different result. In Sweden, we have something called administrative time, and people who doesn't know healthcare, they think that administrative time, that is just filling out forms and doing things for Försäkringskassan. But in fact, administrative time is time when you treat the patients, but not with the standard visit. I mean, you have letters with common mail, you have telephone, because from like 10 years ago, when it was like 5% of the doctor's time, administrative time, today it's about 25%. So it's a large portion of the time, and they don't have video, but they do a lot of the healthcare without seeing the patient. They have the electronic medical charts, they have the radiology, they have the lab results. So beneath the surface, not being measured, there's a big movement of doing things without seeing the patient. It is just that we measure only the video and the telemedicine approach. So when we get the extra, you will see that the big boost will come from things that have already happened, but it's not mediated with video, and I think that is very important. And I don't know how it is in other countries, but from a Swedish perspective, I think it's a big thing. And the last thing, which is very interesting, is you say there were 3 aspects. It was let it happen, make it happen, and help it happen. And you stated very clearly that help it happen was the most successful way. And I can see in Sweden that the ones that have used the approach help it happen is also the ones that has managed to come the farthest. And one of the things that is a big obstacle is our own IT departments. I mean, if you were in the car industry and you were doing combustion engines, who would say, take your own department and make it go away? Of course, it's not going to happen. And I mean, like having the attitude of we want to build everything ourselves, we like to store it on our own things. It's like telling the people doing home visits to build their own car. And so the help it happen approach is successful, and in Sweden we can see clearly that the ones that have used that approach is really the one that have made it, and that is by having their own IT department having a smaller role. And of course, on a national level, we have the Cloud Act, but that is things that will blow away, and no one will talk about Cloud Act in 5 years. So that's one of the most interesting things which I take with me in my further work.
Okay.
I think that was under 10 minutes.
Okay. We'll do like this also for you. Thank you so much. This was an excellent comment, and you had really worked on analyzing the report. Thank you, Ulf. Perfect. Thank you so much. And I'm not going to let you comment on this, Tiago, yet. But even though you're a man, I'm sure you can think of many things at the same time. So you will remember this, and I will continue with directly. Thank you so much, Ulf. Very nice, very nice. Rickard, you are an entrepreneur and you work with patient data. You are CEO for Carmona, also a member in Forum for Health Policy, and you are very engaged when it comes to, or interested in how you can increase communication between healthcare providers and also patients. So from your perspective, I don't know if you have read the report, but your comments on both the report and on digitalization. So please, Rickard.
Yes, thank you very much, and thank you, Carmen, for an excellent report. And I say that everything I read in it, I will sign under, basically, and feel that it's very much the state we're in. And what was new to me was that this wasn't just the Swedish dialogue between different parties. This is a huge international scene you're presenting, and that is really comforting to know. I got the opportunity to make an entrepreneurial perspective on this report, and for me that is about how to make the what into how. Entrepreneurs are the people that are supposed to make it happen. And from that perspective, of course, there is a lot of questions still to be asked, and there is a lot of obstacles on the way to be dealt with as well. And also, as you mentioned, and mentioned in the report, the policy makers, the payers, the politics, mainly are the hardest obstacles to get past. And I guess so in many countries as well. In this issue, we've had some successful small tools in Sweden, like the personal digital ID, mobilt bank-ID. That is a key ICT feature. Other countries doesn't have this up and running, and I can see that is something for them to look at really much, and to get the entrepreneurs make it happen. And on page 41, the Agency for Healthcare Research and Quality in the States, they present 6 points that you also have there, and I think they very much fill in or make your 3 last points very much as part of a bit more to how. They are talking about systematically gathering and applying evidence in real time to guide care. And how to do that, of course, really hard in sometimes to feature, but in others already in place. And there are tools and there are people out there doing it on local level, and there are a lot of initiatives on national levels as well. Doing it from top down, as you say, we have a national dashboard in what we call Vården i siffror, carry numbers, with a bit more than 400 KPIs. But I think in the perspective of making it happen for care workers, it's very far and very slow. So there is a gap between the numbers you need and the numbers you are presented with. And of course there are local dashboards, and there are those caregivers really breaking it down to a few number of KPIs and really working it, and they are doing change. And the third point here, employing ICT to share new evidence with clinicians to improve decision making. Also, how to do that? How to employ ICT to share new evidence? Well, the evidence is out there. There is more evidence than ever. There are more real-world data, more real evidence than we've had ever before. The systems and the processes to transfer it into decisions in the everyday work, the everyday meeting, the everyday decisions, there are still ways to go. But in the combination with best practice treatments and so on, you can really do active decision support systems today. And there are a lot of people doing it. And I say that together with the digitalization of meeting or communicating with the patient, I think these tools will be like a follow-up on that road ahead. There is also a point talking about the promoting the inclusion of patients as vital members of the learning team. And I think that is really just a checkbox on that one as well. And I think together with telemedicine, we have new opportunities to include me as a patient to the team. The team is of course working physically at the clinic, but me to be a part of the team, with telemedicine I can actually be there and I can join the meetings in new ways, and I can share information in new ways than I haven't been able to do before. And capturing and analyzing data and care experiences to improve care. Well, that also stems very well with this other points, and the clinical data is captured today, maybe sometimes too much and too thorough, and with nobody reading it or using it. So we need patient-reported measures to combine this documentation, of course, to make it understandable. And we need data out in real time that can be consumed by all people in the team to make better decisions.
Okay.
Have I made my 10 minutes?
Yes.
Okay.
But also thank you so much. Thumbs up also for you, Rickard, and it's very nice to hear that you're so positive to the report, and Tiago, you can hear that interesting comments also from an entrepreneur here. But I think we'll continue now directly. Also very happy that you read it so closely and had comments from the Swedish side. But we have very short span of time. So Morten, you're a researcher and you have written a lot about digitalization, and your expertise is also the effects of digitalization, both when it comes to labor market, finance, etc., but also when it comes to healthcare. And your comments and reflections on the digitalization and on perhaps hindrances, obstacles.
Sure. Tiago, I was very happy that we met sometime before you published this report, and then when the report came out, it was almost like Christmas. It's very nice that OECD is doing this very important work. So maybe let me just briefly mention two or three perspectives that I would like to perhaps emphasize a bit differently than you have done. And the first one is really about the role of the private sector. I mean, this is not rocket science, but a lot of the innovations that have occurred in the last couple of years has come from the private sector and integrated these kind of technologies into patient-doctor interactions. And here, so we have the private sector and we have infrastructure. Rickard mentioned this bank ID, and I think this is an interesting perspective from the Nordic countries, because the bank ID is a way to identify persons, and it's used so widely in the Nordic countries. We have like 90% of the adult population that uses this bank ID, and that you can see as a kind of infrastructure that enables a lot of other things connected to healthcare, and it's also the basis for other things that can be integrated into the healthcare system. And the bank ID is a private sector initiative. It's not a public one. We used to have the public sector try to do some ID, but it did not come out. So the private sector has a key role in bringing in technology, but also in this national ID. So that's the first point. The second point is about the scaling. I like this aspect of your report, because I think that's really the key to getting cost-efficient and good healthcare, is to be able to scale up these things. So the question, I think, should be for researchers going ahead and for practitioners, what are the obstacles that can be removed in order to scale up these things? Some of the obstacles may be good obstacles, but many may not be good obstacles. And we need, of course, everything has a path dependence, but some of the things that we're doing, maybe we could remove these obstacles, and then we can get more benefits from this technology. So the scaling, I think, how do we scale? That's a key question. And the final point, of course, with telemedicine, you have easier access, you don't have the contagion risk, etc. So you can have an increase of demand, you can have an increase of frivolous demand, but it could also be previously unmet healthcare needs. So you get both an increase in demand and you get a substitution effect. And I think we need to put in place ways to direct and to sort out patients in triage, so we can get more healthcare for less money, but also to sort away those that don't need to talk to the doctors. So here there's an overall challenge that combines the technology, the regulation, and how you pay for things. All those things interact. And here's an area I think that the OECD could perhaps summarize experiences and to help us, because this is really a difficult question.
Thank you, Morten. And you get a thumb up there from Ulf and and from me too. So thank you. And there are so many comments I have myself, but I'm not going to take them now, since I want to move on. Thank you. You'll perhaps come back very soon. Matthias Milbro, I'm so happy to have you on board. And you are, so to speak, a representative of patients today. You founded Young with MS, and I've also written some things you have. I have also read some things you have written about your journey in healthcare. So, what, from a patient perspective, when you hear this discussion and this report, what are your comments or thoughts?
Well, I've read the report and I agree on many of the conclusions. I'm not only a patient, I'm also an engineer, and I work within the medical device industry. So I have that perspective as well, so I will try to give a few comments on the discussion and the report. The COVID-19 situation has forced a lot of persons, both younger and older, across the barrier of entry into using telemedicine. And I think that it's very important to ensure that we keep on using these tools as widely as they are done now, because I'm not sure that the payment systems and the legislations are adapted to make this permanent solution. And I'm also agreeing on the fact that these tools shall be a bottom-up development in collaboration with the patients and with the healthcare workers. It's important not to find a fancy new tool and force it on the organization, but to go to the patients and go to the healthcare providers and actually speak with the persons that are working as close to the patient meeting as possible. And I think it's a more efficient way of working. Perhaps it's very simple digital solutions can cost effectively increase the efficiency. And it's not obvious what those kind of tools are. And also it's important to start developing with a blank slate and ask patients and healthcare providers, and also have a continuous development throughout the phases in order to adapt what's being developed to the needs of the users. And also continue improving the tools after release, of course. Another perspective is that it's very easy to just look at the existing processes and create a digital equivalent. And in many cases, new processes have to be developed, and they need to be kept in parallel with the existing ones. So I think it's a big, it's a hurdle for many people. So there's also a few things reflected on that's related to the limited finances, because healthcare, the finances should go to the persons that need this, the care the most, and those persons are the persons that might not be able to use this kind of tools as much as younger people or more healthier people. And when you have limited finances, you will have to cut some corners. And I'm a bit scared, to be honest, about the increasing amount of patient data that is being collected, and also about the IT security of the tools that is being used, because they need to be patched, and they need to be continuously improved throughout the years. It's not something that you buy once and implement it and then use it. And if you cut costs, the things that is not visible will not benefit. Mm-hmm. But I also see the opportunities to equalize care, because MS care throughout Sweden is very, very different depending on where you live. Yeah. And I think that telemedicine can help this and equalize the care across Sweden. So perhaps you could have a neurologist in Stockholm, even though you live in a rural area far from the city. Yeah. So that's a nice opportunity.
Okay, thank you so so much. You could see all the thumbs you got during your comment, Matthias, right? So,
no, but yeah.
So thank you. Also very important comment from your perspective. Nassim Farouknia, you are a doctor, a medical doctor. You're also director of quality and research at CRY. Is it Europe's largest digital healthcare provider? I think it is. Is it?
Yeah, I think so. Past 2 million digital consultations from start. And as you've heard, I mean, COVID-19, it was a huge increase, not only for CRY or Levy, as it's called in the rest of the Europe, but also for other providers, both private and public providers. So, I mean, thank you very much for all of your comments, and there are so many interesting aspects to address. And I just want to go back to 2 of them. One of them, as Tiago, you also mentioned it, about education. Because, you know, from the start, these digital consultations started in Sweden as a disruption around 2015 and 16. And there is, I think, a bit of reluctance or maybe resistance, because it's about whole new roles for both me as a professional and for the patients, for this kind of co-production that I love a lot. And I think we need education, because we all are educated and trained in a 100% physical or traditional context. So we need kind of education. But above that, I think it's also about building kind of smooth systems. When I started at CRY, I learned a kind of engineers who are called UX designers. So they only work with user experience. And, you know, sitting around the table, different professionals, and actually develop a product that is usable for both a patient and a doctor or nurse or psychologist. Thumbs up. So that's one. And the other one, it's about scaling, as Morten said. I think, you know, in Sweden, I love being a Swede for both bank ID and a lot of other things. However, Sweden is divided into 21 different regions. And, you know, if you start as a company, CRY, and you build a lot of things that work in Skåne, in southern Sweden, then you can bring all your integrations solutions into another region, Stockholm. Then kind of you need to start again. So the scalability is quite poor. So I think my kind of favorite picture for the future is a national common infrastructure, kind of highways or autobahns that are connected to each other for all the data from all the patients and the professionals to be able to talk to each other. It's a patient safety matter. And for all the different providers, entrepreneurs, to be able to just see the road, and there are standards, and then they can make the solutions to help to create kind of smoothness in these co-productions, both for Ulf and me as doctors and for our patients.
Okay, thank you. Thank you so much, Nassim. Daniel Forslund, you are a Commissioner for Innovation and eHealth at the Stockholm County Council, or the region of Stockholm. And just to brief Tiago, Daniel is a politician on the regional level and responsible for providing healthcare to all the people in the Stockholm region. But I would also like to mention to Tiago that Daniel is one of not so many politicians with a deep knowledge and great interest in digitalization, also being head at the national committee. So, but Daniel, since you represent all politicians now at this roundtable discussion, I would still like to ask you about some comments on, especially when it comes to payment legislation And what about getting rid of IT departments, since they are a big barrier, to provoke the discussion a bit? Please, Daniel.
Thank you so much, Katarina. Yes, there are a lot of barriers that we have to abolish, I think, for making the digital care integrated in healthcare in general. Because I think we shouldn't be talking about telemedicine on the one side and ordinary care on the other side. It should be integrated digital physical care. You choose the method which is most effective to this patient, to this treatment, in this situation or that. And that will require a lot of political initiatives and a lot of hard work from our civil servants working in designing the healthcare systems, and a lot of training, I think, both for patients and professionals in knowing how to use these kind of tools. And that's what we are trying to do in Stockholm since many years back. We are trying to have a higher level of requirements towards the care providers to get it happen. We try to help them to get on board by introducing new platforms that are easily available to use. We can see that during the pandemic this spring, we could in only 3 weeks onboard all our 5 emergency hospitals and the university hospital to an already existing online platform for virtual meetings in primary care. That was expanded to the in-hospital care and for visits, for example, for cancer patients, for patients with heart disease, requiring a regular visit to the healthcare system, but they couldn't be there physically. So we can expand that very, very rapidly by having that already available. So I think we will need to work harder from the political side. And what I think is most important is that we now make sure that all the learnings from the COVID-19 pandemic, where we fast forward all the developments that we have been struggling with for many, many years, by help with Kry and other entrepreneurs who could prove to us that actually this was working, the technology was there, the methodology was also there. We could now make sure that the reimbursement systems, the agreements between the payer and the care provider is also including digital care. It should be as ordinary as using your telephone. You should also use video or chat or whatever technology is available for providing security at a distance. That's what I think we also need to solve, both on the regional and local level and on the national and international level, because when we use technology like this, we will also have a more borderless kind of healthcare, which needs to be designed to attract patients on all levels. Healthcare will always be local in some aspects, but it will also be global and national. And that requires that we, between the regions of Sweden, between the countries of Europe, for example, find agreements on how to make this happen. Because if you have a specific expertise available somewhere in a university hospital in Europe, you want to connect that to this specific patient group. It can perhaps be only 1,000 patients all across Europe. You have to design the systems to also include that kind of capacity. But mainly it's a struggle for us locally and regionally, because we are the ones writing the agreements to our hospitals to really foster the knowledge that digital is the new normal in healthcare. We shouldn't go back. We should go forward, and we should make this an ordinary part of our daily life.
So let me just ask you a quick question. Very good. Thumbs up for Daniel also. What we still hear in Sweden being so fast forward when it comes to IT and infrastructure is that we still lack a proper IT infrastructure for the whole country. We have been discussing this for many years in Sweden. Only the thing to read patient information between the municipalities and regions. What would you say is the most acute political measure that's needed to be done?
Well, the thing in Sweden is that we have all the hard infrastructure. We have the broadband connections, we have the IT systems, and we have digital literacy, but we don't have the soft infrastructure, the regulations, the standards, the agreements in place on which standards to use. And going back to Nassim's question about we should actually set the rules for this development in order to make it easier for all the care providers, all the entrepreneurs, all the private initiatives to know which kind of standards, which kind of architecture, which kind of safety should be included in your digital tool to make it easier to introduce and spread a new solution when you want to communicate between in between doctors and nurses, or between the doctors and the patients, for example. And that's what we now are negotiating on starting a formal process between the national government in Sweden and the regional governments of Sweden in the Swedish Association of Local Authorities and Regions. So our aim is to later this year start a process where we set these kind of rules to make it easier for introducing and using technical tools. So the soft infrastructure is my priority.
Is that a thumb up, or you want to say something?
Yes, very short comment. Daniel, if all the patients are using Apple Health and Google Fit as their natural hub, and they're buying their things on a supermarket, do you think the patients will look for the national requirements before they buy their own tools to supervise their health?
Well, in that case, I'm talking about more the online tools for getting treatment, not personal health solutions, because I think we won't be able to control that development. That train has already left. So what I'm talking about now is the interaction between the care provider and the patient. Sometimes you can also find tools for connecting your perhaps personal device to that system, but that will be more on an integration scale, I would say, not for making all the Fitbits and Apple Watches in the world compatible to the Swedish healthcare system. I think that will be up to us to fix that.
Thank you.
Okay, thank you so much. Georg, I haven't asked you in advance to make some comment, but do you have some reflections? Georg is deputy head for Stockholms sjukhem, a care organization for palliative care, among other things. You're also an oncologist, and you have been working a long time in the healthcare system.
Yes, well, I try 2 quick comments, short time. One is to agree on a future where physical and digital care will be totally integrated everywhere. I mean, it's not separate things anywhere. It's electricity in the walls, and to get there, you need to have the payment. So we never pay for physical treatments anymore. Pay for healthy patients.
Yeah.
So those are 2. I think you all agree in this setting, but those are 2 things that you can look for 5 years ahead and further. And then I dive down into my experience, just to give another perspective. So before, I have been worked with the national and regional levels, but now I'm digging down in palliative home care. I see 250 patients we take care of 250 patients every day with physical visits. And the challenge in the pandemic has been, okay, they don't want to see us anymore. What can we do? I mean, they don't want to be they want to be left alone in their homes and get care anyway. And in 2 months' time, 25% of visits were not necessary anymore. 25% in a few months. And we had some things up and running, which was simple communication tools. So one take here that I'm trying to give you is that although I always worked for integrated large systems everywhere, connecting to everything, The important thing here was that the office with nurses and doctors could communicate with older sick patients at home easily, with video, with scheduling, with chat, and it's not fancy at all. And that was the most important step that I can see right now. Not very doctor oncology medical, communication, communication tools.
Yeah.
So that's my take.
Thank you, Georg. When we started, we actually thought we could have an extra 5 minutes. I don't know if it's possible for all of you, but we were promised that at least. So I wanted to ask you, Tiago, listening to all the comments, you got lots of comments from for example, from Ulf and Richard on your report, and as you notice, we are very interested in continuing research also from the OECD about e-health and the effects. But do you have any reflections so far from the discussants?
Yes. First of all, thank you very much for all the comments. Very, very rich. I wish we had a bit more time to go into all the things that were said. So as we have very little time, I'll focus on a few things that I think have come out, a few themes, let's say. One is that these tools are, as I think Matthias said, they're much more than digitalization of existing processes. You need to redesign the services. And one example that goes back to the bank ID is that you need to, even something as simple as knowing who you're talking to when you get on the phone with someone. This becomes an issue that didn't exist in the face-to-face care, where you go to a clinic and you know where you are. So everything becomes a bit more complicated. And this ties into the building blocks behind the digital transformation. And a lot of you mentioned this. You need data governance. People need to feel secure that their data is not going to be misused, that their data is safe, that it's used for their benefit. It's important to acknowledge these issues. These are very important issues that if we don't deal with them, then we won't see an effective use. And if I could point to the OECD recommendation on health data governance, please, I encourage you to have a look there, more from a policy perspective, of course, but there's a lot of things there, like user involvement, cross-border data sharing, that I think are important here. A third point is on data and evaluation. Ulf mentioned that there are some gaps in the report in terms of all the transformation that's happening in asynchronous communication, the use of telephone, less high-tech solutions. We just heard from Jörg as well on this. And that's absolutely true. What the problem is that we don't have that data. I couldn't find the data to show you that. I know it's happening, but it's tricky. And this ties into the problem of evaluation. One thing I wanted to and this ties to Martin's point on frivolous use and unmet needs. One thing I learned from my previous research in telemedicine in a case study in Portugal was that primary care physicians were participating in the teleconsultations, and they were learning about how to refer patients. They were getting more information from specialists on what types of cases should be referred or not. By doing this, they themselves changed how they referred patients. This meant that some people who would have been referred were not referred anymore, and they were treated in primary care, problem solved. Now, what is the problem with this? Is that if you look at administrative data, if someone fills that slot, you won't know that there was a gain in the number of patients treated, and you won't see this in the administrative data. This is important because we need to have evaluation of these solutions, or we'll miss important effects like this one. And this could be one way to convince physicians as well. They were very happy to get these new skills. Finally, after the pandemic, what's going to happen. Are these changes going to become permanent? Are we going to see telemedicine become medicine? And I think in my response to this question, I've been asked this a few times recently, is that we are already seeing some of these changes become permanent. You can look at the US Congress passing some legislation to ensure that some of these investments are made permanent. However, we have to understand that a lot has happened in a very short window of time. And there are structural barriers that will take far longer to tackle. And so we need to do that work. And all of you have mentioned some of these barriers already, and I agree on some of the solutions you mentioned. But it's also important to understand, and I like this quote a lot, the solutions of today are the problems of tomorrow. We have to be a bit careful and learn from the experience so that we don't create more problems. And this ties back to user trust, the trust that my data will be secure. And it ties back to failed top-down or not top-down experiments where we force physicians to institute certain practices, and then they become demotivated. They believe that the digital transformation doesn't really work for them. And this is very, very unfortunate. So going forward, let's make some of these changes permanent, but also let's look at the nitty-gritty, the less sexy aspects of the digital transformation. I think that's my message to finish. Thank you very much again.
Yeah, thank you very much, Tiago. And you have also promised to write a blog article for Forum for Health Policy. Thumbs up for that. And all of you also, Tiago is and all the rest of us, we have now been connected, right? So if we want to have some dialogue with the OECD, we will connect with Tiago, or the latest research in Sweden, we will connect with Morten, and so on and so forth. So which I think is very nice. Peter, you are head of Hinder, the only healthcare organization in the whole of Sweden where you are responsible both for healthcare and elderly care. But you're more importantly chairman for Forum for Health Policy, right? So yes. Some comments to conclude this discussion.
Yeah. First of all, I would really like to thank all of you, Tiago, for this report and this very nice summary of the report, and all of you guys from this very interesting input. A lot of knowledge, a lot of enthusiasm. I don't hear any one of you talking about, no, this will not happen, digitalization. On the contrary, we all know it's here to stay. The corona tragedy has sort of increased our work, what we all want, very, very quickly. So now we discuss solutions and problems and things like that, which you, of course, should be doing. From my integrated care system with elderly care, home care, things like this, as many of you have pointed out, the patients don't want to see us, we don't want to see them. Through this has just exploded. We see one input that we see now in Norrtälje, the old people, for instance, they are so eager to learn about these things, how you mentioned Mobil Bank ID, 75, 80 years old, the ones who don't have it, they want it. Some of our staff, they don't have it, they want it. So I think we have to educate the public, and we have to educate our staff. We are now discussing in my leadership group, my vision is for everyone working in my company, all of them, the staff, to have an iPhone, maybe an iPad, because this is what I use. I sit now with my computer. I don't use it that much, honestly, anymore. I don't know about you. I use these things. And I think going forward, we talk a lot about back end, we talk about problems. I think we should talk more about front end. Front end. When I open this, I have all the most fantastic things in my phone. Apple has taken Spotify, all these things. And I think patients in Norrtälje and globally, they expect the same way to communicate with us. So this is sort of going 5, maybe 10 years ahead. But I also see young kids in our psychiatry book, and unga vuxna, young adults. We reach them now through the phones. We don't get them to they are suicidal. No. They don't come to us. Now, through these things, we can get to them. So, I mean, we have to be more, I think, in what way do the patients want to communicate? Matthias mentioned from the patient's viewpoint. I mean, that's the most important thing. Of course, it should be easy for me as a doctor, things like that. But I think we should see ahead what's coming next 5, 10 years. But I will finish here and just thank you all for this very, very exciting session. I've learned a lot, as I always do when I have these sessions with the Forum for Health Policy. And the international outlook was also very, very rewarding for me. So thank you very much, all of you, and see you again very, very soon.
Thank you so much, Peter. But can you all stay to 1 minute? And I want to take a photograph of you all on the screen. And you should stay, if you could stand up somehow. Ja, om det går. So we could have a nice photograph.
If we stand.
All of you smiling. And perhaps if you stand.
Ska vi stå bredvid skärmen typ, eller? This is a digiphysical photo, Maybe here, I don't know. I don't know how to.
The first one. The premiere.
Jag går in lite bort och bara på skärmen. Okay, should do it.
So thank you all so much, and we will write about this now on the homepage, and you will get an email. And special thanks to Tiago.
Thank you for the report.
Thank you.
Important job. Thank you.
This proves the power of digitalization.
Yeah.
Oh yes.
Yeah.
We will spread the report.
Thank you, everybody.
Thank you. Thanks. Bye.
Jag skrev lite kommentarer, det var intressant att lyssna på Ulf. Sen tycker jag, gud vad bra att han skriver, den här rapporten måste ut. Ja. För ni vet, Curie publicerade nu i en sammanställning av data och det är redan så utskällt av allmänläkaren. De bara visade hela allt. Vad ni håller på med glädjekalkyler och siffror. Har du? Ja, men du har ju sett.
Jag har inte sett den, kan du skicka den till mig?
Har du?